few of our adhesion release methods providers have been asking me if we could record a video of every step along the way, taking on a patient when we get their history and do the consult, when we do their exam, the first treatment, and following up with a few other treatments. Today you're gonna meet Chastity, a 33-year-old woman who's had a year of medial scapula pain and TL pain, and it's provoked primarily with movement or activity, which is a gold nugget for somebody who likely has an adhesion problem, and she did. So let's jump right into it now.
The first step when a patient or client comes in is they fill out the new patient forms, new patient intake form, and then I look at it and we have our history document. So we need to get the first 7-order history information, then we get the 2nd-order information.
These data points are important to get a diagnostic hypothesis. With a diagnostic hypothesis, when I go and talk to her about the history, confirming those diagnostic hypotheses or refuting them, so I have a short list. And then when I go into the exam, confirming a specific diagnosis so that we know when we start treating her, there's a very high likelihood that we're going to get permanent relief at the first visit, ideally. And about 50% of our patients, no matter how long they've had pain, will get some level of sustained relief after the first visit. So that starts with looking at the history and putting our data points in our sheet and then going right into the history, and you're going to see that now.
So she has problems in her right medial scapula and her right TL area. It's primarily aching. So I write down her age, 33, female. She has right medial scap and right TL. So we know she has 2 different spots. I don't know which spot is 3 out of 10. We're gonna ask her, and which one's worse. She has no symptoms at rest. What makes the pain worse? Movement like exercise. So I'll have to find out which exercises provoke it. 5 minutes. It gets worse as the day goes on. Is that with exercise or without? We're gonna ask her. It minimally affects her life. What makes her pain better? Not moving. I assume that's not exercising. Her goal is working out. Her concern that it's non-muscular, maybe it's an organ. That's possible, but if the exercise makes it worse, it's most likely musculoskeletal. It's been there about a year. It's been the same since. She does weights and Pilates 3 to 4 days a week. That's her load. No medications, sleep, and stress is relatively fine. So I go through this and think, okay, so just the right medial scapula with exercises. That sounds like a local tissue. Could be rotatories, multifidus, joint capsule, intercostals. It could also, this is a very common spot for a cervical disc to refer. So if somebody has a disc problem and it can shoot down, that's very common. Could also be coming from her axial or serratus anterior, sends trigger points there. So those are all the tissues I'm thinking about. And then her TL area can be some of those same areas. Could also be the subcostal nerve, the L1 nerve root, which becomes ilioinguinal or iliohypogastric. It could also be stuff in the belly that's overloading the back tissue as the pain generator. So those are my diagnostic hypotheses. So we're gonna talk in the history and we're gonna see what it sounds like it is before we do the exam.
The heart-to-heart hug.
All right.
How are you?
Come have a seat. I'm good.
Good morning, Dr. Christopher.
Thank you.
Just sit here.
Yeah, sit. Thank you for letting us record. A bunch of the providers have asked me to record this process, and so it's just helpful for us to teach. We're going to talk about what's been going on. Most of our patients had pain at least 6 months, seen at least 3 doctors or therapists without the relief they want. So it's important to us that we're not another doctor in a medical merry-go-round for you. As long as this looks like something I can help with a high probability of success, we're going to move forward with the exam, usually on another day, but for you, we're going to do this today.
Okay.
Sound good?
Sounds awesome.
When I go into the room and speak with the patient, the first thing we do is frame what we're doing at this time. So I tell them about how we're collecting data and what we're doing. And anytime you can tell somebody what to expect, it allows them to feel more comfortable and safer subconsciously being in your environment. Just like if you have a child and you tell your child who's watching TV, hey, you have 5 minutes to watch TV and then we're gonna be done. That works way better to get your child to stop watching TV than getting them to stop in the moment. They'll usually, at least my sons, will kick and scream. So if you can say, hey, Baracoa, you got a 5-minute warning till you're done with TV, they will feel way better about shutting the TV off than if I were just to stop it at that moment. So that's why it's important to frame each time you see a patient. The consult, the exam, and all the treatments, it's all the same.
Which of these spots is the worst spot? Inside your wing bone, your scapula, or the one that's lower in your TL area?
So the one behind the scapula is the most constant.
When I asked Chastity what's the primary issue, I want to put the one location in the 7 first order data points. It's important with chronic pain, because chronic pain is hard to fix, that I focus on one location with all of its expression before looking at 2, 3, or 4 complaints. As a younger doctor, or for some of the newbie adhesion release methods providers, they're going to try to put 2 locations or more into that data, and it gets really hard to track and to follow something. We only get the second location or more data after we have the 7 first order data points for that one location. So that's why I asked her the question, what's the priority?
But the pain that I feel in the like intercostals, that's like more severe when I feel it. Does that make sense?
Okay.
So like when I move, like I'll teach a class and then I'll demonstrate some movements and I'll feel it. But like during the workout, I don't recognize it. But then when I move after, I don't know, it's like,
Okay.
it's weird.
Okay. Let's talk about the medial scapula first. So when you say it's constant, you feel it all the time?
Sometimes worse than others, but anytime I retract my scapulas, I could directly.
If you're just sitting here, do you feel
No.
it? Okay. What's the worst that symptom gets to?
Like a 3, I have a
Okay.
very high pain tolerance, so it's hard to like put things on a scale.
So making it worse, you said bringing your scapula back?
Yes.
On both sides?
Like
or
lat pulls, yes.
just doing this now, you feel
No,
it?
just the right side.
But you do feel it
Yep.
now?
And then I've triggered the other pain too by moving in that way. It started shooting down the.
Right now?
Yeah.
Right now, does it connect or is it 2 separate spots?
It's so hard to. It's 2 separate spots.
Okay. 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 Both spots are aching.
Yeah, achy.
Okay. You said
A
lat
little
pull.
stabby with the like the lower rib cage area.
Okay. You said lat pull downs.
Yeah, will trigger.
Both spots.
Yes. And
What other movements or
twisting.
exercises? Just sitting here and twisting.
Yeah, and lateral work like side body. Like
So
bending.
if you rotate to the right, will you feel it?
No pain when I rotate to the right.
How about the left?
No, that just triggers it. No pain. But
What do you
like
mean
sitting
by
here, I
triggering?
actually feel it more when I'm just sitting.
What do you mean by triggers it?
Like it'll wake the pain up.
But you didn't do it right now, so what do you mean by that?
I didn't do it.
You didn't feel the pain right now. so
No,
what
like
do you mean by
like I
triggers
said,
it?
while I'm working, it doesn't hurt. It's like
It's
like,
afterwards.
Yeah, it's afterwards, and then slight subtle movements, like just like
Okay.
the subtle movements.
So after doing twisting, after teaching a class.
People who are younger, let's say 20s or 30s, maybe even 40s, and who are relatively fit, this is something you typically find that their muscles, when they're warm and they're active, the adhesion spot or the pain generator won't be barking at them. And then they'll feel the symptoms later on. So this is something that's been happening with Chastity, and you'll see this a lot of times with younger patients.
Yeah, like waking it up, just like, and you know, usually pain like goes away when you warm your body
Yeah.
up. It feels like it wakes pain up for me. In
How
this
long?
spot.
How long will you feel it in that spot? Just the rest of the day,
Oh, actually,
or like
like
2
this.
days, 3 days?
Extension hurts it.
Okay. How long will you feel it for?
Just a couple like hours, and then it'll go subside until like I wake it up again, and like I'll feel it at night. You know, like after the long day.
How will you wake it up again?
Moving, doing dishes, unloading the dishwasher, just daily, like at night,
Okay.
picking the kids up.
Okay. When you say flexion or extension, what do you like right now or after doing in your class?
Like just now I was moving, and then I went like that. I could feel it actually the most. I feel it during extension.
Both spots?
Nope, just the
Top spot.
no, the bottom.
Bottom spot. How bad? 0 to 10?
3, 4, 5.
How
Like-
bad does that lower spot get to?
Like 5. Like nothing extreme. Like nothing will stop me. Like none of these pains will stop me from doing
Okay.
anything.
Okay. Got it. So that's immediate. Retractions immediate. Lat pull downs are immediate. Okay. Anything else make the upper spot worse?
What I notice is that it's all connected to my neck. Like that's that right side that I came
Okay.
in here initially
Okay.
for.
Okay.
When I turn to the left, I have limited mobility to the left side.
Do you feel that the
Not to the
scapula
right.
spot when you turn your head? Or is it just your neck?
I just feel it in my neck, but I could just feel like the connection. Like I could just feel it. I could like know that that's
So
all
it does
connected.
make it a little worse then.
Yeah.
When you turn your head to the left, do you feel that medial scapula spot a little bit?
I feel it pulling. I feel like the whole
It
pull.
pulls. Like a 1 out of 10 and 2 out of 10?
No, like mild, like 1.
Okay. How about turning to the right?
Nothing.
Okay. So with that symptom, we know that your disc is a little bit involved,
Okay.
which is very common for that spot. Any other motion that makes the medial scapula symptom worse?
No. Nope.
Okay. How do you feel in the morning when you get out of bed?
I actually lately, which is a very new, and I don't know if I nurse at night and like I side lie because of the baby a lot. I've been feeling very like heavy here.
In the
It's like
mornings?
a weird, yeah, like closed off in the front, and then like, whoa, I never felt that before, and I have to like roll my shoulders back, so more like here.
Is
I
that
don't
the
know if
only
makes
time you
sense.
feel that area? Is it in the
Yeah,
morning?
yeah.
Okay.
But that's it. And then, you know, like the
Okay.
low back, 33-year-old low back.
33. God bless. Children.
You're so old.
What is there anything else that makes the lower spot worse? You said after so the bringing the wing bones back, lat pull downs after teaching classes, both spots, correct?
Yes.
After teaching class?
Yeah.
And then when you feel it after class, both symptoms are there and both symptoms go away at the same time?
Because the lower symptom is so radiating, it's hard for me to feel 2 pains at once. So I don't even notice the lat, but I've noticed that for the longest. The lower side feels connected to it, but it's not as constant, but it's getting more and more constant.
Okay.
Does that make sense?
Yes. And it's most severe after teaching a class.
Yes. I like playing at the park with the kids, throwing them on
Yeah.
the bed.
Got it. Okay. Anything happened a year ago?
Physically,
Yeah.
I can't say.
Emotionally, lots of stress.
Lots.
Yeah. Have you ever had any pain here before a year ago in either spot?
No, I've never had like scapular pain.
And in the lower TL spot?
No. I've had like low back pain, neck pain, but never like the mid back like this.
Okay.
So this is new-ish.
Okay. How often do you have low back pain? Every day?
Now, like after my 3rd child, pretty steady. But
Where is it?
it'll go away.
Where?
Like lumbar, like completely.
But where?
Like
Is it like
right
one spot?
tailbone, like above the tailbone.
Right in the middle?
Extension really triggers it. Yeah, in the middle, not one side.
When else do you feel it besides extension?
Bending over.
Like touching your toes?
I'll feel the stretch, but no pain. It's more like going up dog, like cobra.
What does that feel like? Achy,
It's-
burning, stabbing, sharp, throbbing?
Achy, but it's days on, days off. Like some days it's excellent and I could go full
How bad will it get? 0 to 10?
5. It'll never like feel like excruciating pain.
Okay.
It's more achy.
Okay. And so you'll just feel it just sitting or standing or moving around?
Never sitting. I don't ever feel my low back painful sitting. It'll usually be during extension.
So it's just
inflection.
during extension. That's the only
Extension
time.
and flexion, yeah.
Okay. And then your neck, besides turning your head, do you feel it any other time?
Oh, Yeah, that was wild.
Do you feel it any other time? Besides turning?
Nope. It's turning to the left.
That's it?
It feels like something's impinged.
Okay. Anything else you think I should know?
No.
Do you have any questions for me right now?
No.
Okay. We're gonna do an exam.
Okay.
Normally, Samia does the exam. I'm gonna do it just for the purpose of filming and stuff.
Okay.
Do you have a tank top on or anything?
I have a sports bra.
Okay. We'll leave that on for now, and then when I
Okay.
feel stuff, then
Okay.
we'll get in there.
Because we did the exam on the same day that we did the consult for the purpose of this video, I didn't do a great job of framing that. Normally what I say when they come in for the exam is, first, do you have any questions? I answer the questions or not. And then I'll say, okay, here's what we're gonna do today. We're gonna provoke your various symptoms. We're gonna measure your flexibility, your range of motion tests, and then we're gonna palpate and see where you have adhesions or where your nerves are entrapped. In adhesion release methods, we call this PRP. This is the data we're collecting at the exam. Provocative tests, ranges of motion, palpation. Those are the three most important things that we need in order to fix chronic pain. We don't need to see if the C5, C6 joint isn't moving or subluxed in a certain way. We don't really need to check static alignment, although we will sometimes on the ankles or the spine, but that's not super helpful. Sometimes people say my one shoulder is higher than the other, and it's hard to know, is this shoulder good and this shoulder bad, or is this shoulder bad and this shoulder is good, and which one's normal? So we don't use static alignment as much as we use flexibility tests or ranges of motion. We tell them we're going to give you a diagnostic hypothesis, we're going to talk about your expectations of relief, and then you're going to talk with Kim, our patient advocate, and decide if you want to proceed with a fee per visit or a case fee. And then we'll typically jump into treatment the day of the exam. So that's the part I skipped because of the same day exam with the consult, but that's what we usually say.
So I'm gonna do abbreviated neck and low back stuff and then get into the thoracic spine. Come on all fours for me, please.
This way?
This way.
Measuring low back.
Correct. May I lower this? Thank you. Crunch your belly up. QLF is 0 to 3.5 inches flat. What do you feel?
Nothing.
Nothing at all.
Nope.
Okay.
Until I go really deep, then I feel something.
Where do you feel that?
Low, like when I tilt my tailbone all the way in and scoop my belly, then I feel like here.
0 to 10.
3.
Zero to 3.5 inches flat. That is 72% function. On the left side or in the middle?
Middle.
Midline.
It's more actually on the right, to be honest, like on the right side of my spine.
Okay. 0 to 10 pull?
Pull?
Yeah.
I would say like a 7.
Okay. Come and stand up, Chastity. Stand here facing this way.
With shoes or take my shoes off?
You can leave your shoes on.
Okay.
Samia, come take a note for me. Right knee down, left foot forward. So bring your knee to the, yep. Flip this foot over, please. Bring that foot 2 inches forward. Bring that knee forward as far as you can. Keep your chest up. KHE on the right. It's really good. 16 inches, what do you feel?
My iliac is in psoas pulling.
Here.
Here.
3 inches under anterior hip, 0 to 10.
7?
Pull.
Yeah.
Okay, come and stand up, please.
Chris, can you explain the tests as you're doing them just very briefly?
Kneeling hip extension primarily is checking the psoas and the femoral nerve, but it could also check other stuff. She may have some stuff at the femoral nerve under here at the psoas iliacus tendon. So this function needs to be over 12 inches. She's got great range, but she probably has some entrapments right in this area. And then other stuff like LFCN, the nerve roots, medial psoas, the femoral trunks, those won't be coming out in this test. So then we just know we have to palpate those. Come and stand up. Stand here and face this way. Left knee down, right foot forward.
I don't know my left from right.
You did great. Bring that right knee forward as far as you can. Sorry. 14 and a quarter. What do you feel?
Nothing, funny enough, and I thought, oh, I am righty, okay.
No symptoms.
Good.
Come and
No,
stand up,
this is
Chastity. Knees straight, touch the ground, please. Palms touching the ground, skirt range. What do you feel?
Good.
Nothing.
I feel like, you know, like a little nice little stretch.
Where?
And my hamstrings.
Bilateral posterior thigh.
Right, tighter.
0 to 10 on the right.
5.
5 and 4 on the left.
3.
3 on the left. Okay. She says hamstring. We never say the muscle tissue because then we could fool ourselves, and then I just look for the hamstring. So posterior thigh is the region, and that's how we look at the spot. Can you bend backwards for me? On top of standing extension. Bend backwards.
Like how far? To the floor?
I mean, don't go crazy, but what do you feel?
Nothing.
No symptoms.
Nope.
Good.
So I guess it's more upstretched than, like when I'm on the floor with my hips on the floor, that's when I feel the low back.
We're gonna do that in a second.
Okay.
Bring your wing bones back. Let's just do with your arms down.
Oh.
Retract. What do you feel?
Funny, that's when I feel it. I didn't feel it when my hands were up.
Okay.
Your hand's right on it.
CCX. The medial scalp spot, 0 to 10.
Right now, 3, 4.
Pain?
Like a little poke, yep.
Like a pinch.
Yeah, pinch.
4 out of 10 pinch. But if you bring your arms up and then do that.
It's gone.
Okay. So there's something probably preventing her scapula from getting all the way backwards when she moves her arm. There's some other tension, but it's beyond me right now. Can you do up dog, please?
Oh, my low back feels nice.
What do you feel?
Nothing.
Anything, anywhere?
I feel the scapula right now.
This one,
Yep.
0 to 10.
Like a 3. Nothing insane.
Pain?
Like the pinch, yeah.
Pinch. Anything at the TL spot?
No, I don't feel the...
Okay.
My low back is definitely not having the best time, but I don't feel pain.
Okay. Got it. Okay, come on up. Do you have your phone? Can you get the rotation app, please? I don't think I need to do the whole come and back to the wall. I'm not gonna do the whole cervical, but we're just gonna get ranges for rotation. So when I say go nice and slow, you're gonna turn your head to the right. Okay, slowly turn right. Keep that left scapula on the wall. You can put this on the low back form. 60 degrees, 66%, it's horrible.
Pull. My hair is sticking to something. There's Velcro here,
Yeah.
Christopher.
Left posterior scalene area, sorry. 0 to 10 pull. Stand here. 0 to 10 pull when you turn to right.
Oh, that was actually like a 6. It's pretty tight.
6 out of 10. Look straight forward. Wait for me. Okay, slowly turn left. 68 degrees, 74%. What do you feel?
I feel, that's so weird because I thought I had less range here. I feel like a little pain here and like an impingement back here when I turn left. Like,
Right C3, posterior C3 area, 0 to 10 on the right.
it's like a 6 pull still.
6 out of 10 pull on where on the left?
I feel it here, but I feel the pinch over here. Like
Left
here.
C4 area, pinch, 0 to 10.
Like the pinch is like a 6.
6 out of 10. Okay. Can you get thoracic rotation? Come sit here, love. Feet straight down in front of you, knees together. You're gonna hold like this. Thank you. Keep your knees together. Don't let them come apart. Turn as far as you can this way. 56 degrees, 101%. You feel anything?
I feel the pinch in the right.
The TL spot.
Up a little, up. So towards you a little. Up, in there.
Right bra strap under scapula, 0 to 10 pinch.
That's like a 7.
7 out of 10.
Yep.
Straightforward. Is that the spot? So it's up higher than, so
It's like,
here.
it ranges. It's like, it goes like, I have a low bra strap, by the way.
Okay,
So, yeah, right here.
okay. Knees together. Don't let them come apart. There you go. Turn to the left, please. Keep your knees together. 51 degrees, 92%. What do you feel?
I felt it more on the left side. Nothing, like it just feels like
Where
I'm
on the
stuck.
left side?
It just
Same
feels like I'm
spot?
stuck.
Same spot?
Yeah, like tight, but nothing, no pain at all. Just
Left
tight.
under bra strap, under scapula, tight. 2 out of 10?
Yeah, like it's tight. It feels like
2?
a pull, like
2.
a 3, 4.
4 out of 10.
Pull. Yeah, not pain.
2.5 inches flat from C7 to T2. Then the next fulcrum point was right here. 2.5 inches flat from T2 to T4. The next fulcrum point is right there. 3 inches flat from T4 to T6. So you have to just lift the stuff out of the way so you're on the skin. And that is horrible. 0 to 4 inches flat from T9 to T12. Do you feel anything with this?
You have a way with words.
Just being honest, just being
I
honest.
do. I feel like a pull here.
Right here. Pull at the right T11, T12 area.
When I
When
slouch.
we bring our head down or we round or do lumbar flexion, everything should be like a nice hill. This is good function wherever we're looking. Typically we want to see less than 2.5 inches of flatness to have good function. But if we have a spot, she had a couple spots where it was like 2.5, I think there was another 2.5 rounded, and then down here it was just flat for 4 inches. So these are restricted areas of function. So I would expect to find adhesion here, here, and here. And she has symptoms too. So the combination of her symptoms with the provocative tests and these ranges just tell us where we want to look.
For those of you who've been doing adhesion release methods for a while, you'll notice with the exam, I didn't do the straight leg raise and supine hip flexion first, which are part of primary low back and hip complaints. And the reason why I didn't do those is because I didn't think they were super relevant to her case with the medial scapula and the TL area. If I thought they were super relevant, I should collect that data so that I know what's going on. I was right because after 3 days, she was 100% better. Any of the data or the exams or the provocative tests or the ranges of motion, anything we palpate should be relevant to what we think the diagnostic hypothesis is. When you're beginning with this adhesion release methods diagnostic process or critical thinking process, if you're a massage therapist, it's probably better to get more data because you might not know if it's going to be relevant to whatever you think their pain generator is. But as you move along with maturing in your thought process and how you're thinking about people's problems, then you should be asking yourself, is this relevant or not? Whether you're right or not, you should just have a good reason if you're talking to another adhesion release methods provider why you did or didn't do that information, because that allows you to own your thinking. And so if you just do or don't do something and then somebody asks you, why didn't you do that? And you're like, I don't know. That's not a good answer, because then you're not doing the meta learning process that comes from figuring out if something is relevant to fixing chronic pain or not. So just in case you were wondering why we didn't do straight leg raise or supine hip flexion, that's why.
What I typically do is on the exam sheet, I put one complaint and then I put the second complaint, and I like to highlight because it just makes it easier to see where things are. So for example, her location 2 at her right TL area with thoracic flexion down here provoked that symptom, so I just put it in green. And then with the other stuff, bilateral scap retraction, 4 out of 10 pinch, under the bra strap. When she rotated to the right, she fell under the bra strap. So that's the bra strap pinch, rotation to the right. Up dog provoked her medial scapula, but she had no TL symptoms. And left bra strap tight. So we have right rotation to the right provoked the under the bra strap symptom and thoracic flexion, and then scap retraction and up dog provoked the medial scap symptom. And then what I like to do is I like to draw stuff on the folder directly. So her chief complaint, just so I see this every day, is her right medial scap. Location 2 was right T10, T12. And the chief complaint was provoked by bilateral scap retraction and then up dog. And then right TR and thoracic flexion provoked CCX2. So up dog is primarily extension, scap retraction. There's some extension there, but could also be armpit stuff. And rotation to right thoracic flexion is primarily stability stuff for the spine, rotatory multifidus joint capsule. Bring your wing bones back. Here?
To the right a little bit?
Here?
Mm-hmm, under there.
Okay. A little what?
A little lower. Like
Lower.
You're right around there,
Right.
yeah. Mm-hmm. Mm-hmm.
So what I'm gonna do, it's always helpful to mark areas. So she was feeling that right. It's just a body marker.
Ah,
It's a Sharpie.
stickily.
Okay. Cross your arms across your chest, please.
Like,
Yup.
so.
Yep. She's got a lot of tone in this area. It's gonna make it harder for me to feel stuff, but it also just tells me that there's stuff that's messed up in this area. I wanna avoid the tone, but I wanna note where it is, because if we remove the right adhesions, it's gonna make everything, it's gonna make the tone relax and things will soften.
What does tone mean?
It's like you're contracting your bicep.
Okay.
Like it's just doing that without you actually doing these things. I would say right T6 to T9 multifidus,
like
rotatories is moderate to severe. It's like what?
Reflex?
Maybe. You can call it that, sure.
Tone, trigger points, knots, hypertonicity. It's what happens when your muscle feels like it's contracted. It's like somebody's making a bicep and it feels like the muscle is just tight and contracted. That is not what adhesion release methods providers treat, because we found that when you push on those spots, people may feel great leaving the office for 24, 48 hours, but the pain always comes back. Adhesion is fibrous and dense and gluey, and it has a different texture than increased tone, what I just said with Chastity feeling her mid-back. So we need to look for where the tissue is adhesed, not where it's hypertonic or trigger point or knotty.
Is it protection?
Yeah, yes, it's a protective response. Her right T10, T11 joint capsule is moderate to severe.
You're like right in the space.
Right T7, T8 joint capsule is moderate to severe.
Oh, that's it.
So rotatory multifidus, I check that going towards. and I'm looking for tissue that's going this direction. The joint capsule's going up and down. Primarily we use rotation away to see if that's pulling tight. Her levator costorum at right T8, T9 is moderate to severe. Sorry.
It's okay.
Right T11, T12 levator costorum is moderate to severe. So I'm looking for smoking guns. I'm looking for things that are really bad. Right T12L1 joint capsule is moderate to severe. So with both of those tests, some of those rotatory multifidus can hit two birds with one stone. We can hit the scapular retraction symptom up higher, an up dog symptom, and we could also affect thoracic flexion and rotation. So Occam's razor is if there's one problem that can affect multiple things, it's likely that that's the culprit. So far I'm really happy with what I found there. I am going to check a little bit of the belly stuff. Femoral nerve at psoas is pretty clean. Femoral nerve at iliac is at L4 is moderate. Yeah, there's nothing major down there. Then I check the nerve roots medial to the psoas. I'm pulling the psoas up off the nerve roots. Mild to moderate at L1, and then the psoas at diaphragm. Mild to moderate.
Something's happening there. Something's happening there.
L1 nerve root lateral to psoas, mild to moderate. Yeah, there's some little stuff in there. On your back, please. Yeah, it's so funny. So serratus anterior can refer right to the medial scapula, but first I'm gonna start high.
I didn't shake my armpits either.
You're good, dude. There's nothing. There's nothing here.
It's mostly seeing Chris's hand anyway.
There's nothing here. Proximal NVS is moderate, not horrible. Second ICB is clean. Hit the long thoracic nerve at serratus anterior. LTN at SA is mild. Serratus anterior doesn't feel too bad. So I'm guessing that scapular retraction symptoms mainly due to the extension, not due to serratus. So SA is clean. I could do the nerve roots at the scalenes and the neurovascular sleeve at pec minor, but I don't think that's a huge priority right now. She does have neck stuff, but we could do this all day because she has 4 complaints, but we're focusing on the thoracic ones. Chastity, I think I have everything I need. I'm gonna take a look at my notes. We'll come back and talk, okay?
After we do the exam, I say what I just said to Chastity. I go outside where I have space and I can think clearly and I'm not worried about the patient being in the room, and I look at all of the data and I cross-reference all of the exam findings with the history findings. And on the back of our history sheet with Adhesion Release Methods, we have a form that we call diagnostic duck hunting, with the idea that if something looks like a duck and quacks like a duck, it's most likely a duck. But if something doesn't look like a duck and doesn't quack like a duck, it's not a duck. So there are green light benchmarks for when a specific data point is indicated towards a specific pain generator. So if somebody has butt pain that is worse when they wake up in the morning, when they're sitting, when they stand up from sitting, that looks like a disc problem. If they have butt pain that happens only when they're walking on their right leg and only when it's balancing on itself on just that right leg, that might be a glute medius or a superior gluteal nerve problem. That doesn't look like a duck and quack like a duck. So we need to figure out all of the data points and whether they are green lights, neutral, or red lights for that data and that diagnostic hypothesis. And we want as many green lights towards that diagnostic hypothesis as possible to know that we can be very confident in their diagnosis. And because adhesion release methods providers are typically pretty expensive and we charge for cases, maybe $5,000 a case, it's important that we be as close to right as possible. That doesn't mean that I'm perfect. It doesn't mean that I'm right all the time. Generally speaking, that about 80% of the patients we accept on as patients are going to get some level of sustained relief they're happy with. But that means that 1 out of 5 people, they have really messed up discs or joints, or they have other metabolic problems or other emotional problems, but we want to be as confident as possible. But that 80% success rate, it's better than most surgeons and most other chiros, doctors, and therapists. So we just need to do all of our due diligence to make sure that we're doing what is right by the patients and the clients we see. And that's why it's important to take that time to cross-reference all of our data, do our diagnostic duck hunting, and make sure that our diagnosis and or our pain generator is correct. And if you're a massage therapist and you can't tell them the diagnosis, you still need to know in your head what's going on so that you're doing what's right by them. And you won't be able to charge premium rates that people can trust that you're gonna do what's best by them if you don't do all the steps. Looking at the data, cross-referencing the data, diagnostic duck hunting, and then going back and communicating well to them.
When it comes to permanent relief, it's a matter of diagnosing you correctly. The more we get your diagnosis correct, the more permanent relief you have now, the more longevity you have as you get older. Make sense?
Yes.
One problem, it's a big deal, adhesion. And normally I put peripheral nerve entrapments here, but I didn't feel any specific nerves, I don't think. So the good news is that this problem is fixable. And we're one of the only clinics in the United States that specializes in fixing it. We have patients flying in from all over the place for this, so you're in the right place.
And this is exactly what I say in the report of findings. The simpler and shorter you can make it, the more concise you can make it, the better this is gonna go. As far as earning the patient or the client's trust, you earn their trust by following all these steps. And then when you palpate all the areas that are their pain generators or that provoke it, and they're like, wow, I didn't even tell you where my spot was, but you were pushing right on 10 of those primary spots, that's how you earn their trust. So I don't have to talk to her for 20 minutes to earn her trust and to let her know that she's in the right place. I've already earned her trust with everything I've already done now. So you're gonna see a relatively short and sweet report of findings. It works better than talking for 20 minutes.
Here are your spinous processes, here's your scapula. You got muscles in here called rotatories and multifidus, and these were very glued up and stuck in here. There are a bunch of other things in there as well. The joint capsules are here like this. There were a few spots where that was glued up and stuck. All of this is gonna cause tightness and weakness. What we're gonna start doing today is start chipping away at this glue and this adhesion till it's gone. We get flexibility and strength back, and we get rid of this problem tissue by tissue, layer by layer.
90-second report of findings. Short and sweet. She already knows she's in the right place. I don't have to speak more to that. I asked her questions, or asked her if she had questions. She asked me and we answered them. But most providers talk too much with the report of findings. You already earned their trust. You don't have to talk more.
Questions or thoughts?
Is there something that could be triggering that glue to, I'm using that word because you always use that word, to keep coming back? Is there something that I could be doing and am able to avoid doing?
Yeah, nothing right now that's top of mind. I chalk up some of this to the fact that we live, and I mean, I really like Pilates, but there may be some areas where you have some weak spots where you're just not maintaining strength. So what we're going to do, I'll probably give you a couple exercises and you can tell me how they compare to the things you're doing with the Pilates that are very effective, and we'll see if this helps at all. But most of it, I don't know.
I strength train too.
Yeah, okay. It's hard to, like, I don't know who's, adhesions is the most ubiquitous, common problem in the musculoskeletal system, causing problems. So this is why what I'm doing and what we're doing to teach this, to get out there, is such a big deal, is because most people don't even know it exists. 9 out of 10 of our patients have never heard of it before. And when you get rid of it, people also get sustained relief. So when muscles or nerves are overused, the body lays down adhesion. So we want to maintain strength. But as we get older, I don't know how to avoid, for some people. Having a baseline level of strength that's not too little or too much is the best we can do to stay healthy long term.
So what's the difference between this and fascial and trigger release?
Yeah, so first, trigger points, we don't treat those. They're secondary problems to degeneration or adhesion. So first, most people do not get any sustained relief with trigger points. So that's one of the ways we market, because most of the people will agree with us. Sometimes on social media, people will tell us trigger point work for me. I'm like, great, I'm happy for you, but typically it doesn't lead to lasting relief. Fascial work, this is a form of fascial work.
Yeah.
Adhesion is fascia when it's bundled up and glued up and stuck in an area. This is just way more precise.
Okay.
I'm trying to treat 4 to 8 spots each visit that are stuck. I'm not doing a whole 90-minute Rolfing session over 10 sessions doing your entire body. It's just very precise with all the data we collected, and we retest to see, I want to feel that this little spot of adhesion dissolve and melt away. And we are physically breaking up that adhesion to make it go.
That makes sense. Thank you.
We have a really aggressive goal here to help 250 people each year get out of chronic pain. Once we're getting you some level of sustained relief, can we count on you to let 3 other people you know in chronic pain about us?
Absolutely, I know a lot of those.
Okay.
Notice after I answered her questions, I implemented the mission-based referral system. It's one of the lowest hanging fruits for our Adhesion Release Methods providers to get other patients or clients in the office. One of the easiest ways to get people in the office is to have somebody who you've helped who had chronic pain. They have friends and family they know in chronic pain, because who doesn't know people in chronic pain? And then you just prime them and you say, when you're better, can I count on you to tell 2 or 3 other people that you know to send them into this office? And it takes me 30 seconds. And then when they're better, you say, hey, remember when we told you about our mission? Do you mind sharing those 3 other people that you know about the relief you got? Or you could even give us their information and we'll have our patient advocate, Kim, call them and let them know that we're here to help them. It goes a very long way. It's one of the lowest hanging fruits, the easiest things that providers can do. If you're not an Adhesion Release Methods provider and you fix chronic pain, you should be doing this as well. It works like gangbusters, and go ahead and start implementing the mission-based referral dialogue.
Turn to the right for me right now. Not like that. You feel the pinch right here?
No, I do.
7 out of 10.
It's like more.
It's a little less
Yeah.
since I've been poking around.
Yep, like 4.
Okay. Good. Come on back. That's her worst provocative test, so I'm primarily going after that first, because if I can make that 7 out of 10 better, I'm hoping it's gonna get some of the other stuff better. I just wanted to be more specific about what she was feeling, and I also wanted to see where her spine looked like it was rotating and where it wasn't. Right T10, T11 rotatories. Good. Severe. So I'm just doing this with my thumb because my thumbs are so that's why I'm doing this different strategy, but typically we should be coming in here like this with the flat thumb. but that's already much softer. Rotate to the right.
I got a little crack.
0 to 10, still 6.
No, 4.
Okay, 4 out of 10. So 1 pass and we reduce the pain 33%. Straightforward.
If you're an Adhesion Release Methods provider and you're seeing me treat rotatories or multifidus, you're gonna see me going in the wrong direction that we treat it. My hands have been really bad. I haven't been able to get good treatment on my hands, and so I can't go the typical way where we're doing external slide with rotatories or multifidus, so I'm flipping my hand and going the opposite way. I'm just calling myself out because that's not the way that we teach how to do rotatories and multifidus in the thoracic spine. I'm sorry, I'm not doing it perfectly, but I'm just trying to do whatever is effective for the patient because my thumb gives out when I go the opposite way.
Tons of tension. Right T67 rotatories, moderate to severe. Turn right. 0 to 10.
I don't know, I still feel your thumb in me.
Okay, so you can't tell.
No. I feel like I don't feel a pinching in that space anymore, but I still feel the thumb in me.
Yeah. Okay, so no pinch,
I want to vomit.
just sore from the thumb.
Okay.
Do you feel the tone loosening up? Or soft?
Yes. Still got pockets, like right here is a pocket, but it's softer around that. So often what you feel is if there are a bunch of, if I feel tone like this in a bunch of different areas, it'll often be like pockets like this. So now she's got a big spot right here, but a lot of this is softer, this is softer, this is softer. So it just allows us to focus and see where we continue to feel like things are not moving the way they need to. Right T10, T12 rotatories, moderate. Arms down by your side, wing bones backwards. Scap retraction, Samia, 0 to 10.
I don't feel. Wait, I feel.
0 to 10.
I don't feel anything
No symptoms. Good,
in my scapula.
good. I could be done now, but I'm probably gonna check a couple more things. Arms across your chest. So now I'm gonna just scan the joint capsules. And these feel softer because the superficial multifidus rotatories are a little better. I'm feeling a spot down low down here. Right T11, T12 joint capsule. This is not great. Moderate to severe. T1201 joint capsule, moderate to severe. Do you have your phone? Feet flat for me, knees together. As far as you can to the right, please.
Final?
Knees together. Yes, final. As far as you can go. Here, don't hold on me. 60 degrees, 108%. What do you feel?
I don't feel the pain.
You feel pulling?
I mean, I just stop, but there's no like,
It's just
it
no
doesn't feel
specific
like-
pull.
yeah, it doesn't
Okay.
feel like
Good.
something's pulling.
Really good. So we did scap retraction already, and that was full. And then I'm up dog on the table, please. Zero to 10.
Nothing in my scapula, nothing in that.
Beautiful. No symptoms, really good. One more, come have a seat and face the doorway. So I don't have to do all 4 of our provocative tests, but if you have time and space, come have a seat, my friend.
I thought you said
If you have time and space, it's helpful. If you know you treat stuff and it makes one test better, it doesn't make other tests better, it can be helpful to cross-reference what you have and just know what's helping and what's not helping. So I don't know, up dog could be getting, maybe there is some type of arm involvement with pushing her down, or with her low back, with the lumbar spine extending. So that information would come out with the different tests. Chin to your chest, slouch, 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 slouch. Yeah, good. So I'm mainly curious about her lower thoracic spine, where she was flexed for 4 inches. I would say she's still flexed 4 inches, or a flat 4 inches. Do you still feel any pulling with this?
Yep.
Where is it? More in the lumbar spine now. So T12 to like L4, pulling 0 to 10.
Like a 6.
6 out of 10. Good. Okay, so that's probably her low back stuff that
Thank you.
she was, some of the belly stuff potentially was causing that, or something in the low back that we have to check. But I'm very happy with this. So the treatment worked. I felt the tissue softened. We released some of the tone that we were talking about, the hypertonicity, and we changed a lot of tests. So this is exactly what we want to see. You may be sore tonight or tomorrow, so Samia will give you a text tomorrow and check in on you and see how you're doing. And then next time you come in, we do some tests, you report in, we treat same stuff, different stuff, whatever, we retest, and this is the process of unlayering you.
Like an onion.
That's right.
Thank you.
Exactly like an
Just
onion.
more onion under.
More onion. Any questions or thoughts for me?
No, thank you so much. Yeah, I feel it.
And I'm gonna try to give you an exercise right now, which maybe you do something similar to this. Come, let me have you stand up, please. So your chin's gonna, we call the first part of this canister, so it's a neutral spine. It's probably gonna be very similar to what you do Pilates. And then we're gonna add a scapular retraction exercise to keep the lats engaged. So your chin gets tucked in a little bit, so you're neutral. You tuck your wing bones all the way underneath you, away from my ears. Notice that my ribs popped up here. Then I'm going to bring my ribs down here until I'm neutral. I didn't flatten my low back, but I'm neutral. Squeeze my butt, contract your lower pelvic diaphragm, and then brace your abdomen. This is the canister. We just breathe. Then from here, palms up, elbows about an inch in front of the midline, then nice and slow with my wing bones tucked in, keeping them locked. I externally rotate, and I come back. Was that 4 or 5 seconds? I'm making sure my scapula stay locked down and back. You try it. Tuck in a little here, good. More under, more, good. Good, good. Feet apart a little bit, good, squeeze. And then, Kegels. Elbows in front a little bit, good, keep those locked. Nice and slow, externally rotate, and then come back nice and slow. Don't lose the scapular lock.
This is Pilates.
Do you have an exercise like this?
Basically, not with the complete scapular retraction, but.
Okay, I think that part's important for you. But yeah, this is why I like Pilates, because it's really good on activating and stabilizing the most stuff. So
I can tell this is weak.
Okay, good. So we're gonna do this. We'll start with like 2 sets of 8 reps every single day.
Okay.
Got it? Mm-hmm. Good. You can take that home with you.
Thank you. I have one.
With that similar resistance?
Yeah.
Okay.
That helps. Thank you.
I feel the need to share with you, after looking at the console exam and first treatment, that my energy is very low. I'm again calling myself out. I definitely struggle with depression on days, and if I'm not on top of how I'm showing up and presenting, everything is very low vibration, and I apologize for that because it doesn't make for a great video. The patient was happy and she got better, so that's the most important thing. But ideally, when I'm presenting, I'm happier and more energetic for you guys. So I'm just acknowledging that I don't really like the way that I presented. I'm being okay with it for now. I hope you are, and I hope you enjoy the second and third treatment. So when the patient comes in for the next treatment, they sit down with our clinical assistant and they give a report of how it went. Are their symptoms any better? Are they worse? Are they the same? What's better? What activities? What movements? What postures? What load did they put on their body? Is there anything else they want to make us aware of? And then the assistant comes out and talks to me so I can again look at my notes and decide what's our plan of attack.
She's got right mid-scap. Standing here right now, it's a 2 out of 10, but she's also feeling kind of a T12 area on the right side.
That's what we worked on last time.
Yeah. And then your prerogative is up dog. How is it with that?
Well, I don't wake up doing up dog, so. I'm tight today. I feel like my belly's tight, but no, I don't feel any pain.
Nothing in the back?
No. Just low back kind of stuff.
Any movement make the scapular area worse?
I think like twisting and lifting at the same time.
Okay. Twisting to which side? You feel like twisting to the right or to the left?
Right.
To the right. Okay. And then after last time's visit, do you feel as though you had relief in symptoms?
Yes.
What percentage?
I would say like a 50 to 60%. Like I don't feel it all the time triggered. It's just like now, like end of the day kind of overusage, but.
Okay. Do you feel as though the 50 or 60% lasted until now, or did it only last for a few days?
It's only been a few days.
Right, so like, did you feel like it lasted a day, 2 days, 3 days, or you feel like it's lasted all the way up until today?
Yeah, actually like immediately it was like a lot better.
Okay.
And then like, it was kind of been like yesterday, I guess at work.
It kind of like regressed a little? Okay.
A full day at work.
Gotcha. And then overall percent improved from your very first appointment to now. I know it's hard because it's appointment 2.
Yeah, like 50 to 60.
Still as well, okay.
Yeah.
Okay, we're gonna do some quick testing on you.
Okay, cool.
Just sitting there, would you retract your scaps for me back?
With my hands up or down? Down.
Yeah, just down. I think. How does it feel here?
I can still feel a little tiny pinch in my scapula, but way less. Like
0 to 10.
Like a 1. I'm like aware of it. Might be like in my head at this point. No, it's there.
It's never. It's there.
It's there.
Okay. Let me pull up this. Okay. I'm gonna have you put feet together, knees together for me. Yep. And then you're gonna hold this across your body like that. Beautiful.
Make sure you call out the measurement.
Yep. Okay. And then go ahead and turn towards me. 50 degrees. How do you feel here?
I felt good until I started rotating back.
Like at the
When
end
I
range?
started rotating back home.
Oh, coming back this way.
Yes.
Gotcha. Okay, what did that
I just
feel?
felt like like a pinch.
A pinch? 0 to 10.
Like a 3, 4.
And then this one I'm just gonna have you do. I'm not gonna actually measure, but this one I want you to hunch everything down. So like hunch here, hunch down everywhere. How does it feel in this position?
Fine.
No pulling anything in the back.
My low back.
Pulling in the lower back?
Yeah.
0 to 10 there.
I would say like a 6, but we weren't really focused on that.
I know, but it's still important to know.
Yeah.
So you saw that our clinical assistant Nasima did some of the same tests that we did at the exam, and then after we did treatment 1. In order to get sustained relief, we want to see that those tests change sustainably from visit to visit. Their symptoms had reduced, and hopefully their range of motion improved. When the range of motion improve, usually the symptoms follow. We want to be different than most other commodity generalist pain providers because we need to provide sustained relief. And the way that we primarily check that is to hold us accountable with the tests. When we're not doing tests or we do a reassessment after 8 visits or 16 visits, that doesn't really earn patients or clients' trust too well because they just spent all this money and all this time and they're waiting till a month or 2 months later. So we Adhesion Release Methods providers, or you chronic pain specialists, whatever you're doing, just check them before and after every single treatment. You just got 2 data points in that one visit, and you get 16 data points in 8 treatments compared with other chiropractors or PTs or whoever who are just checking them once at visit 8 to see if they're any better. We can be better than that. You can be better than that.
Yesterday there's just like a little regression. That's when she started to feel the symptoms come back.
Which spot?
The right mid scap.
What
And then
about this lower spot?
she said I think this is where you worked, she said, and she's feeling it just more today.
She had 2 provocative tests for the medial scapula, and she had 2 provocative tests for the lower TL area on the right. So I'm looking at the up dog was 3 out of 10 pinch. It was nothing today, so that's better. I need to find out about scap retraction, and then thoracic rotation. Okay, so she had a 1 out of 10 pinch, so that's 75% better. So really good. And then her TL area was rotation to the right. So she felt the medial scapula now.
Yes, but only when she was rotating back. She didn't feel it while she was rotating away.
Okay, so rotation to the right is now the worst test. So 7 out of 10, now it's a 4 out of 10 pinch. So we have the 2 spots. So this is 50-60% better?
Yeah, like this is like really good. Like I
This
just
is
feel
good.
like a little
Down here.
Down here.
Percentage better. 90?
No, down here it has to be like, up here is like 90% better. Down here is like 50.
Okay, so 90% at the medial scapula, 50% at the location 2.
Also, it's really hard for me. I had 3 natural births. It's pain relativity is very tough.
You do the
It's
best
a
you can.
very tough
You do the
like
best you can.
topic. I don't believe anything hurts until like a baby's coming out of me.
That's fair. That's good.
So this spot is 50%. What makes this spot worse?
So she was like, rotate this way, and this is fine. And then when I came back, it hurt, but I can't like
In this area.
trigger it every time.
The
It's
lower
like,
spot.
It's like there. Yeah. Mm-hmm.
So there you go. Do you feel it right now?
No.
Arms across your chest. Do you feel it now?
Yep. I feel a pull.
Trying to decide whether I want to go after her armpit or whether I want to do. I want to check your psoas. Face this way. you. So this is so as a diaphragm, which when it's tight, it will cause overload at the TL area in the back. She's got a little spot right here on the lateral edge. Go.
What?
Nice. $40 at the door. It's chiropractic joke. Chiropractic joke.
I'm pretty sure that was my doing, so.
So I'm checking her psoas, femoral nerve, the stuff in the belly, because especially above her umbilicus, so L3 or higher, because anything that's adhesed or glued up there is going to put a lot of load on the TL, T12, L1 area of the spine because it's directly in front. There's something that we talk about called axis of rotation in adhesion release methods. If somebody has pain in the back, if they're very adhesed in the front, clearing out the front will make the pain in the back. A lot of times providers will hammer the C7, T1 area when they need to clean out the nerve roots or the anterior intertransverse in the front, and that will clean out the back. If I treat the back area without treating the front, oftentimes a patient can get very sore and then come in the next time and they're like, I'm 0% better, because that's not where the problem was. The problem was on the opposite side. So you clear the axis of rotation, the joint can move more cleanly against each other, and that's what will allow the symptoms to go away.
Easy. Go. What'd you do?
I made bread.
Oh, sourdough?
Yeah.
Good.
Did you get into the whole sourdough kick right now?
I am on the sourdough kick.
Sourdough
I've been on it
treat.
for a while now.
Yeah? You got a little feed in your little guy going?
Go. This is our L1 nerve root, lateral psoas, becomes the ilioinguinal and iliohypogastric nerves. That was worse than the psoas at diaphragm. Come on up. Psoas at diaphragm, 2 passes, moderate.
Nothing.
No symptoms?
No.
Good. And the L1 nerve root lateral psoas, moderate severe, 1 pass.
You did this one, correct?
Yes. Arms across your chest. Relax. There you go. And she's got a lot of contraction here. There you go. She was holding herself tight, but it's still got some tone in her erectors.
And now that I've cleaned out the front, I am checking the back side, probably L1, L2, somewhere joint capsules to make sure those are clean as well.
Sorry.
It's a
Her rotatoris multifidus is not great, so we're going to treat that now. Right T10, T11 rotatories. Moderate. That's better. Right T11, T12 joint capsule. Moderate. Right T12 L1 joint capsule. Moderate to severe. Good. arms across your chest. Turn right. What do you feel?
I don't feel anything right now.
Nothing. How about left?
Nothing.
How about bringing your wing bones backwards? You said 1 out of 10.
I don't think I feel anything.
Nothing.
No.
Scap retraction, 0 out of 10 symptoms. Come on over here, please. Knees, chest, face.
Here? Knees here?
Yes, ma'am. And relax.
That is very tight. Oh, there.
Yeah, I feel it. L1L2 joint capsule on the medial side. Crunch your belly up. Crunch, 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 crunch. Good. Moderate. What segment did I just say?
L1, L2.
Go. 2 passes. Good. Come on up, love. Lie on your side facing this way. Lie back towards me, your whole body. Yeah. Yeah, I know. Go. Good. That's better. So it's that same L1 nerve root on this side.
Mm-hmm.
Go. This is the inner transverse. Drop the knee down more. Good. Slouch for me. You still feel 6 out of 10 pulling in the low back?
I feel like a 3 to 4.
Thoracic flexion, her left PSIS area, 4 out of 10 pull. Okay, good. So that change was 6 and more general. We're doing great. The SEMA is going to remeasure, making really good changes. The tissue is softening, so we're removing adhesion. Let's do one more visit and we should be able to clean out whatever else is there. Are you doing that canister exercise we gave you?
Sure.
You're full of shit.
Liar.
I know you do Pilates too, but...
No, I like thought about it a couple times for sure.
Okay, well, it's progress. A little bit there.
Yeah.
make sure you do that exercise.
Okay.
It's a part of you staying well.
Okay.
And the Pilates is great, but that specificity, like if you can add the retraction to all of it, it's gonna help.
When a patient doesn't do their exercises, I tell them, you need to do your exercises. This is a part of your treatment plan. Sometimes people think that it's just an optional thing. When we give somebody exercises, we expect them to do it. It's a part of their care. They're spending a lot of money in our care. It's our job to make sure they're doing what they need to do to get better. And so we need to be confident in what we're telling people so that they will listen to us and do what we say. It's important that we get people better. We can only grow and help more people get out of chronic pain when every single person in our office trusts us as much as possible and we do the right thing to get them better. I can't tell you how many patients I've lost. I can think of 4 off the top of my head in the last 3 to 4 months who stopped our care because I asked them hard, annoying questions that they did not like. And that's okay. It's my job to get people better. So if people don't want to answer the questions or they don't like the fact that I asked them questions that other doctors wouldn't ask them, then I'm not the right provider for them. But if somebody's overweight and I'm going to tell them, hey, you need to lose weight, and they don't like it, that's not on me. It's my job to fix people. It's our job to fix people. So we need to say what needs to be said. Doing their exercises is a part of it. And she's young and she got away with it. She got good relief. I still need her to do those exercises. If she doesn't do them with those 3 treatments gone and she's done right now, then she's gonna have to come back in sooner than later.
Questions or thoughts for me?
When you say nerve root, what does that mean? Like when you're working on a nerve root?
It's a nerve as it comes out underneath the psoas muscle. One of these guys.
And they're attached to the belly, come through?
They're deep. They're underneath the psoas muscle. There's the psoas, that filet mignon muscle, L1 nerve root. So I don't know which one. I was on one of these nerves right here as it comes out of L1. If it's glued up and stuck, it'll cause a lot of contraction protection. So that contraction will overload the tissue on the back.
Okay.
In this area.
That makes sense.
So most of the work that we do in here, especially with chronic low back pain or TL pain, 80-90% of it is the front.
Okay.
Because what we used to do is just hammer on the back and we would get some relief, but when we started doing all the belly nerves in the front, it got just way better relief because we're increasing the capacity of the low back or the TL area by asking it to do less work. Okay. So if this isn't contracting so hard, then the back muscles don't have to compensate and contract from the opposite side.
Okay.
You see, I got the complete anatomy app by Elsevier. I don't hesitate to show people what actually tissue looks like. People will often appreciate it. There are even times where I don't even know what I'm treating and I go and get the app and I'll say, let's see what this is and try to find it. And they like that we're trying to figure stuff out as we're doing it. Don't hesitate to not know answers and to be curious or to share with them stuff like the anatomy so that they own what their problem was and they will appreciate it.
All right, I'm gonna remeasure you. So feet together, knees together. Same thing, just cross your chest here. Go ahead and rotate towards me. 61.
Wow.
How do you feel there? Anything?
I felt nothing coming back.
Nothing?
I feel, I would say like a 1. I can still feel it.
A pinch?
It's still there.
Still at the lower?
Subtle, yep, right underneath there.
Okay.
But it's way less. Like I didn't feel like the shock of it.
Yeah. And that is it, my dear.
Thank you.
Thank you.
It's like a walk in here and the pain goes away immediately.
I love that.
She said, walking here, the pain goes away immediately. We want to have such good energy and be known for such good relief that we activate some placebo in them and they suggest to themselves that just walking in here, they'll be getting better. There is subconscious mechanisms involved with getting people better. So we want them to be hopeful, to know that relief is possible. It's gonna help them feel good about just being in our office.
Same spot?
Actually, yeah, it's the same stuff. The scapula one, it's like 0, it's like 0 to 1. That's it. When I feel it, but there's no pain. It's just like an awareness of that spot. The twisting thing, it's way more mild than it was before, but it's still like it makes an appearance sometimes. again, after like a long day or in the middle of a lot of working out.
Sitting here right now, can you feel it?
No. Even after like moving, I don't feel it, but it has made an appearance, but way more mild, way more mild.
And really just more like at the end of the day?
Yeah. Mm-hmm.
And at the end of the day, what is it, 0 to 10?
It will become like a 2 or 3, but nothing like that is stopping me from anything.
Okay.
I will say, my low back has been like tighter. It just like trickles down, but
Both sides of the lower back?
it's more right than left. But then I notice, so it's all my right side. I know I commute 2 hours every day.
Okay.
I notice I lean like the entire time like this.
Oh, like while
I
you're
try,
driving?
Yep, I try to straighten up, but I notice that might be triggering it. Like two hours a day is a lot of driving.
Absolutely. What is your lower back right now, 0 to 10?
When I slouch,
Nope. Just
or
normal.
just sitting, nothing,
Nothing.
0.
But when you slouch?
When I slouch, like when I bend over, that's like a 6, 7 of pulling and a little ache.
Okay. How do up dogs feel now?
No pain in the in that like
Scap?
yeah, no
Nothing
scap
at all?
pain, no.
And then how about seated with a little scap retraction? How does that feel?
I don't feel anything. No.
And then how are you feeling first thing in the morning?
Tired?
That's fair. Body-wise, any tightness, any stiffness?
No, actually when I get out of bed I'm pretty good. I know what it feels like to not be able to move.
That's fair. And then overall percent improved from your first time until now. Last time for the mid-scap you said you're like 90%, and then for the like rotating area you said 50 to 60.
Yeah,
So you're
I would
saying
say
better
like
or worse?
98% with the scap, and then the like that spot down here, I would say like now 70% better.
Let us roll into the little testing then.
Alright.
We're gonna do the rotation one first. So knees together, feet together. Good. Just cross your ball. And then rotate toward me. Good. Good. 57 degrees. How do you feel there?
Fine, no pain coming back.
Nothing going either? No symptoms at all?
No, just like pulling, like
Pulling
you know,
where?
like a stop.
In that spot?
Like this whole, you know, like
This whole section?
yeah,
Okay. 0 to 10 on that pulling.
like a 3.
3?
Yeah, yeah.
And then just the one where you kind of like slouch for me. Slouch, 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 slouch. Any pulling, any tightness, anything?
No,
Nothing at all?
no. It's only when I hinge.
Right,
The
at the
hips.
hips for the lower back?
Yep.
Okay. And then I'm gonna throw a different test today. I want you on your stomach for me. Lift this leg up. Good. Relax this leg. Good. What do you feel here?
Nice. Nice little stretchy stretch.
Where? In the front of the thighs?
Not really.
No?
I don't feel much, no.
Where do you feel? Anything? Any pulling, any tightness? Anything in the lower back at all?
No.
Okay. And I'm gonna do the same thing on the left side, just to see. Sometimes when we do these tests, it'll provoke lower back symptoms. So I always try to
Yeah.
gauge them and see.
Nothing.
Nothing at all? Good. Alright. And then what about standing up and touching your toes?
It doesn't, because I'm like so flexible, it doesn't hurt if I fold,
Okay.
but if I round,
Yeah.
if I scoop, then I feel the pull.
Okay. And then what about coming up? Any difference?
No,
Down or up?
no.
Just because someone is flexible does not mean they don't have adhesion, excuse me. There are certain tissues that when they're adhesed are definitely gonna limit touching their toes. If the sciatic nerve is entrapped to the external rotators, it's gonna be restricted. But for example, sciatic nerve entrapment at adductor magnus doesn't have to limit that range of motion. So that's why range of motion tests and palpation will help us really clear out all adhesions throughout the body. So just because somebody has good flexibility does not mean that they don't have adhesion. Somebody could be really flexible and have a lot of chronic pain, and they go and see a physical therapist, and physical therapist says I'm good or I'm healthy, but they didn't know to palpate the stabilizing structures that would be involved in overloading the pain generator. So make sure you're palpating as you're doing your range of motion tests.
I think my problem is like I know too much, so like I engage certain things to prevent the pain, but
Right.
if I'm just moving freely, I'm aware of it.
0 to 10 on lower back in that position when you
When I scoop
Yeah.
on this right side, right here.
Right in here.
Yep. Like a 3 to 4. Yeah. I think I actually feel it more sitting.
When you do that?
Yeah.
Okay.
Than like the whole hang.
Okay.
Weirdly enough.
Okay. Alright, let me show these to Dr. Chris and then he will be on it.
It's giving him more problems.
Mid-scap really is just kind of a dull one, just barely feeling it now. That like T12 area, she's not feeling it all right now. Really, she only feels it at the end of the day after movement. Increases to a 2 and 10. Her new symptom is now she's noticing her lower back.
0 to 10.
Right now, just sitting there, but when she kind of like bends forward while seated, more of like a slouch, she feels it.
Is that bothering her the most?
Yes, out of these. Yeah.
Good to see you.
Your low back's bothering you the most now?
Yeah.
Come facing this way, right knee down, left foot forward like you're at the bottom of the bench. Bring this knee forward as far as you can go. KG on the right.
Any day after all.
14 inches, what do you feel?
My Achilles tendon over here.
Bring that left foot further forward. Yeah. What do you feel now?
Now I feel a pulling in my hip flexor.
Here?
Lower. There.
Pull proximal anterior thigh 0 to 10.
6.
6. Okay, come on up. So it's primarily with slouching for a while that you feel it.
Yep. Like this motion.
But yeah. Where's the one? Come on all fours for me, please. Face this way. Crunch your belly all the way up. Good. QLF 0 to 3 inches flat. What do you feel?
The pulling in the low back.
Where? Pull midline L4 to S1. 0 to 10. How intense?
Like a 4. Yeah, it's not normal. I'm not just like having pain there all the time.
So she's probably not stabilizing as well as she could there.
Oh,
Cold?
no, that spot.
Sensitive?
Yeah, no, a little higher. Yep, around there.
Okay. She also had a little bit of her low back was in a big area, was hypertonic or contracted. So that usually tells me that the femoral nerve or the lateral femoral cutaneous nerve is entrapped. So that's what I'm doing now.
How do you know that's not an organ?
It's not. It's a femoral nerve. Because I go to push it and you jump. I am pushing through intestines, but they're basically soft. They just move out of the way. Go. Good. You okay? Go. This is LFCN now. The Iliac. Keep going, keep going, keep going. Good. One more. Go. This is straight up Iliac. That's going really nicely. Good.
Can you define pulling nicely?
Come stand up.
Come stand up.
Just a lot of tugging. So normal tissue, if it pulls, it'll just pull a little bit like this. But if it really tugs a lot in a short range, that tells me that it's really bad. Femoral about 5. Touch your toes for me. Mild to moderate, LFCN iliacus, moderate. You still feel it? Iliacus, moderate to severe.
I feel pulling, but less.
0 to 10.
It's like a 2.
What was it before? 4.
4.
Let's check the other side. Face this way, Chastity. Slide a little bit more back here for me. Yes. How are the kids?
They're good.
How's Chris?
It's good.
Is he?
Yeah, everything's good.
Lean against mine. There you go. There you go. So this side's actually a little worse. There's a lot of femoral cutaneous nerve. Right there. Go. Yeah. So within the first 2% of that motion, it was already tugging, which tells me that it's entrapped and stuck. Good. If it were healthy, it would pull later or tug a lot more gently into my finger. Go. Good. That's way better. Do one more out here. Go. Good. Come on up. LFCN iliacus, 2+, 3 passes. Touch your toes. Still 2.
Yeah, I could still feel like a 2 here.
No change. No change.
Notice I gave Nasima, our clinical assistant, how many passes I did on the tissue. It's just a helpful way to be honest with yourself about how much work you're doing. When I used to do active release technique, I don't know, maybe 20, 30, 40 passes on a patient, my hands were effed. At one point I thought I'd have to quit practice. So I really focused on trying to do 5 to 8 treatment passes per visit. If I can do less than that, that's even better. If I can do 5 to 8 treatment passes per visit, I'm gonna be able to treat 20 patients in a day. 20 times 5 is 100, or 20 times 8 is 100 to 160 passes in a day. That's not gonna overload my hands so much so that I can continue to function. Even though I do have hand issues, I'm still able to treat well until I go and I get more treatment on my hands. How often are you holding your little guy? You still hold him a lot, don't you?
Yeah. I think it's really the sleeping. I'm still nursing, so it's like a lot of sleeping funny.
Right.
Between 3 bodies. I was telling her though, I just realized, you know, I commute 2 hours a day, forward and back.
That'll add, yeah.
And I lean to the right when I drive.
I'm trying to get it out. It's hard to keep depth when... Good. Right 405 medial joint capsule. Moderate to severe. You're gonna touch your toes again.
I'm looking for it, but I feel like I have to look for it to find it. I feel like it is a little
It's called a 1.
looser. Yeah.
Okay.
A 1.
Line your side face, Greg. Just a branch of the superior cluneal nerve that goes inside the PSIS. Feels a little stuck right here. So we're gonna do hip flexion.
Mm-hmm. Give me this leg.
Go.
Are you putting a nail on me on purpose?
No.
Oh, that's what I feel the most.
Yeah, I know.
Okay.
I try to keep my nails short, but sometimes when you're trying to get deep in the tissue, I don't know what, besides taking my fingernails off, which...
Stop wearing those press-on nails, Dr. Crest.
I know.
That won't happen.
He wants to feel bonita.
Go.
Don't Leo.
Good. Good. Come on up, touch your toes. L3 superior cluneal nerve, medial to PSIS. 2 passes, moderate to severe.
It's gone.
Good.
I just feel your nail in my back now.
Yeah, I know, I'm sorry. You're doing the canister exercise?
Yes, I just did
Okay,
it.
cool. Awesome. Nasima's gonna measure those tests, but we're doing great with these. Let's see how you do with these 3 treatments.
Beautiful. The difference between experiencing this type of adhesion release and other things that I have tried, such as a chiropractor, and massage, right? Like massage will give you like a feel-good temporary, but I really do feel like once he goes in there and finds those things very, the word is like, it's sciencey. Like he goes in, he's taking actual measurements and feeling for actual things, not just like feeling around. Like if I showed him where my knot is, he's not just trying to get that out. He's looking for like root causes. And I think that made a huge difference that I've never experienced. And I'm actually feeling the release from it. So really appreciate this work. So those scratches on the back.
I know. Dr. Chris and that. All right, crunch your belly up for me. Good, how do you feel here?
Much better.
Any pulling at all?
A little bit, yeah.
0 to 10.
I get 2 of pulling. 2?
Nasima, what was the measurement?
0 to 3.5 flat.
Okay.
She was 0 to 3 flat to begin with.
Right.
And then pulling went from beginning of 4 out of 10 to now a 2.
That was it. 3 treatments after an exam and after a consult with Chastity. If you're an adhesion release methods provider, I hope this was valuable for you. If you could either comment on the video or message me or email me what valuable nugget you got from this, it will just be helpful so that I know how I can help you learn better and be more efficient in your treatments. If you're not an adhesion release methods provider and you want to become a non-surgical chronic pain specialist and stop being a commodity generalist and focus on fixing people in shorter, more efficient periods of time and be able to charge premium rates, it's extremely rewarding to know that you're delivering chronic pain relief and also getting paid what you deserve. If you're a good doctor or therapist who's fixing people, you deserve to get paid well. And as adhesion release methods providers spread and as we get the word out, we'll figure out ways to make this more economical for people who can't afford those high rates. I want to get this out there so that all people can afford our care. So I hope this was valuable for you. Feel free to share in the comments what you got from this. If there's any other videos you'd like to see, let us know and we will work on making those in the near future.